You know, when you hear about the American healthcare system, it's easy to feel lost in just a maze of information.
It really is complex.
So for this deep dive, we're really on a mission to cut through some of that confusion. We want to give you a clear understanding of what the system is, where it came from, how it functions today.
The controversies, too, which are significant.
Exactly, the debate surrounding it, and maybe most importantly, its impact on your life, on all of us. We've looked at a lot of ground to bring you the crucial insights. Okay, so where does this whole story even begin?
What's fascinating, actually, if we go way, way back, before European colonists even arrived in North America, indigenous communities had really quite sophisticated and holistic approaches to health.
Holistic, yeah.
Their understanding emphasized this deep connection between mind, body, and spirit. It wasn't just fragmented parts.
It's a whole different way of thinking about health, isn't it? We tend to isolate the physical, but they saw it as part of a larger harmony, like that concept of walking in beauty. It really captures that.
It does. And it wasn't just philosophical. They had an incredible working knowledge of plant-based medicines, a really rich traditional pharmacopoeia.
And they performed surgery too, right?
They absolutely did. And it's crucial to remember the devastating impact of European diseases on these existing systems. That significantly altered the health landscape right from the start.
A tragic side effect of colonization.
Definitely. When the colonists arrived, they brought their own medical ideas, primarily Galenic humoral theory.
Ah, the four humors.
Exactly. Balancing blood, phlegm, yellow bile, and black bile. Treatments like bloodletting and purging were common ways they tried to restore that balance.
Which probably didn't work so well against unfamiliar diseases.
Often not. These methods frequently weren't effective against the new diseases and conditions they encountered here in the New World.
You can just imagine those old European remedies weren't much use against something like smallpox here. So it sounds like the colonists had to figure things out pretty quickly on the ground.
They did. I read that they did start to learn from indigenous practices, incorporating local plants into their treatments sometimes.
Necessity is the mother of invention, right?
Absolutely. Now, the extent of this knowledge transfer is debated by historians, but there's definitely evidence it happened.
Okay.
Early colonial medicine was also very individualized. Families often provided care themselves, or they relied on local healers, maybe religious figures.
So not really formal doctors as we know them today.
Formal medical training was quite rare, yeah. The lines between different healthcare roles were pretty blurry.
So then moving into the 18th and early 19th centuries, cities start growing.
And with that comes, unfortunately, outbreaks of infectious diseases. Smallpox, cholera, malaria.
Must have been a really frightening time to live in a city back then.
It was. And the prevailing medical idea at the time was miasmatic theory, the belief that diseases were caused by bad air or miasmas.
So they thought foul smells caused disease.
Essentially, yes. This led to some early public health measures, things like quarantines and some basic rudimentary sanitation efforts, trying to clean up the bad air.
Then the American Civil War, that seems like a huge turning point, though obviously a tragic one.
It really was, for the development of American medicine.
Yeah, this is where it gets really interesting, I think. The sheer number of casualties just forced rapid innovation, didn't it?
It absolutely did. They started using anesthesia routinely, chloroform and ether. That was revolutionary for surgery.
And they kept detailed records, too, right? Some of the earliest safety data?
Exactly. The medical records from the Civil War are incredibly detailed. Plus, they developed organized ambulance corps and rudimentary field hospital systems. That really laid the foundation for our modern emergency medical services.
Wow. So emergency care has roots way back then.
It does. And perhaps one of the most significant developments was the large-scale introduction of antiseptic and aseptic techniques in wound care.
Even before germ theory was fully accepted.
Right. There was this growing practical understanding of the importance of preventing infection, even if they didn't fully grasp the mechanism yet. Military surgeons started implementing practices to keep wounds clean, and that dramatically reduced mortality rates.
Incredible.
The war also spurred early advancements in things like plastic surgery and even neurosurgery, simply because of the nature of the traumatic injuries they were seeing.
It's amazing how much progress can come out of such incredibly difficult circumstances. So after the war, late 19th century, we start seeing the medical profession organizing itself more.
Yes, exactly. The founding of the American Medical Association, the AMA, in 1847 was a key step.
And what were their main goals initially?
Primarily, to elevate the standards of medical education, promote scientific advancements, and crucially advocate for the licensing of physicians. It was moved towards greater professionalism and regulation.
Okay, makes sense.
And around the same time, public health began to emerge as its own distinct field.
Because people realized individual health wasn't just about the individual.
Precisely. There was a growing recognition that health was closely linked to social and environmental conditions, especially in those rapidly growing, often unsanitary industrial cities.
Right, things like clean water, sanitation, they weren't just nice to have, they were essential for stopping disease spread.
Exactly. And you had figures like Lemuel Shattuck. His 1850 report in Massachusetts was groundbreaking. It documented urban mortality rates and strongly advocated for creating boards of health.
So that report really laid the groundwork for our public health infrastructure.
It absolutely did. By 1869, Massachusetts had established the first statewide board of health, and by 1900, something like 40 states had followed their lead.
Wow, that's pretty rapid adoption.
It shows the growing awareness. Even before that, states were enacting quarantine laws for diseases like smallpox, demonstrating this early understanding that government had a role, a responsibility, in safeguarding public health.
So as we head into the 20th century, we have medicine becoming more professional, the beginnings of public health. But how are people actually paying for care?
Ah, yes, the payment piece. Well, at the dawn of the 20th century, most hospitals were still semi-charitable. They relied heavily on philanthropy, but they also charged fees if patients could pay.
Which meant access for the working class and the poor was pretty limited.
Very limited. And a serious illness could easily lead to financial ruin.
Plus, medical care itself was starting to get more expensive, right? With new technologies.
Exactly. Advancements like X-rays, new vaccines, they were wonderful, but they added to the cost. The old pay-as-you-go model was becoming increasingly unsustainable for a lot of families.
So people started experimenting with different ways to manage those costs.
Yes, you started seeing some interesting early experiments with group payment plans. Things like fraternal societies and labor unions setting up sickness funds.
It's sort of like early insurance pools.
Kind of, yeah. Providing financial assistance to members when they got sick. And some employers even started making direct arrangements with physicians to provide care for their workers.
But the really big moment, the one that kind of foreshadowed modern insurance, was the Baylor Plan in 1929.
That was absolutely the watershed moment. Justin Ford Kimball at Baylor Hospital in Dallas.
Right. Tell us about that. Baylor Hospital was struggling financially.
It was, yes. This was right as the Depression was hitting. And Kimball noticed that local school teachers, while not wealthy, had steady jobs, but were really worried about unpredictable hospital bills.
So he came up with an idea.
He did. He proposed a plan. 1,250 teachers could prepay 50 cents a month.
50 cents.
50 cents a month. And that would cover them for up to 21 days of hospital care at Baylor if they needed it.
That sounds like an amazing deal for the teachers.
It was. It gave them security. And crucially for Baylor, it provided a stable, predictable revenue stream, especially vital during the Depression. It was a true win-win.
So what started as just a local solution for one hospital and one group of workers
unknowingly planted the seed for a system increasingly reliant on these third-party payers, on insurance.
And that idea spread pretty quickly.
It did. The success of the Baylor Plan led to the growth of similar hospital service plans in other cities. Soon, you had citywide plans that allowed people to use multiple hospitals within a network.
Which helped stop hospitals from, fighting over patients?
Exactly. It addressed that patient poaching issue. And these plans were the direct precursors of the Blue Cross system.
And then Blue Cross became more formalized?
Yes. In 1946, the American Hospital Association established the Blue Cross Commission. It acted as a national oversight body, initially focused just on inpatient hospital expenses.
Okay, so Blue Cross for hospitals. What about doctor's visits?
That came slightly later. In the late 1930s and early 1940s, we saw the development of Blue Shield plans, specifically to cover physician fees.
So Blue Cross for hospitals, Blue Shield for doctors. Got it. How did the doctors themselves, like the AMA, feel about this?
Well, interestingly, the AMA was initially somewhat skeptical of these prepaid plans.
Really? What?
They were concerned about potential third-party interference in the doctor-patient relationship. They worried about losing autonomy and control over medical practice if insurance companies started dictating terms.
Concerns that maybe still echo today in some ways.
They absolutely do. But despite that initial skepticism, these community-based nonprofit Blue Cross and Blue Shield plans really introduced that fundamental concept of health insurance pooling risk across a group and laid the essential groundwork for the employer-based system that would become dominant later.
And that employer-based system really took off after World War II, almost by accident, wasn't it?
In a way, yes, it was an unintended consequence of wartime policy. During World War II, in 1942, the government implemented wage controls.
To stop inflation during the war.
Exactly. So employers couldn't just offer higher salaries to attract and retain workers in a tight labor market. They had to find other ways.
Like offering benefits instead of wages?
Precisely. They started offering non-wage benefits, and health insurance became a particularly attractive option.
A way to compete for workers without breaking the wage rules.
Correct. And then came a crucial ruling in 1943 from the National War Labor Board.
What did that ruling say?
It declared that employer contributions to health insurance premiums were exempt from those wage controls. And crucially, these premiums were also deemed non-taxable income for the employees.
Wow. So employers could offer it and employees got it tax-free. That's a huge incentive.
It was an incredibly powerful combination. Suddenly, employers had a strong reason to offer health insurance, and employees received a really valuable benefit without paying taxes on it.
So that led to a huge boom in employer plans.
Massive expansion. The proportion of Americans with private health insurance more than doubled just between 1940 and 1950. It quickly became the dominant form of coverage for the working middle class.
And then the government solidified this even further with the tax code.
Yes, in 1954, the federal tax code formally codified this exclusion. Employer-paid health insurance premiums were officially not part of an employee's taxable income.
So that tax advantage basically subsidized this specific type of insurance and really embedded it into the American system.
It absolutely did. But this created a kind of bifurcated system, right? Where your access to health insurance was increasingly tied to your job.
So the working middle class got coverage through their jobs.
The wealthy could always buy private plans directly.
And who was left out?
The elderly, people with disabilities, and the very poor. They were largely left uninsured by this growing employer-based system.
And people started noticing this gap.
Oh, yes. Studies in the 1950s and early 1960s really began to highlight this growing divide. Millions of vulnerable Americans lacked coverage and faced huge financial risks if they got sick.
And that lack of coverage for the elderly and poor really set the stage for the next big government intervention, didn't it? Medicare and Medicaid.
It absolutely did. That gap became a major impetus for federal action. But it's important to remember the idea wasn't entirely new.
Right. President Truman had proposed something much earlier.
Exactly. Harry S. Truman was actually the first president to propose a form of national health insurance, way back in 1945.
Wow, 1945. What did his plan look like?
He envisioned a universal system, financed through payroll taxes, basically ensuring everyone had access to coverage. A single system.
But it didn't happen then. Why not?
He faced fierce opposition. Powerful interest groups, especially the AMA, fought it tooth and nail.
What was the AMA's argument against it?
They launched a major campaign labeling it socialized medicine. They raised concerns about higher taxes, government bureaucracy, and a loss of physician autonomy. All the classic arguments against government-run healthcare.
And the political timing wasn't right either.
No. In 1946, the Republicans gained control of Congress, and that effectively blocked Truman's bill. It was a huge disappointment for him. He really believed in it.
But the idea didn't die.
No, it simmered.
Yeah.
And the political climate evolved. By the 1960s, under President Lyndon B. Johnson, there was a real window of opportunity.
LBJ and the Great Society programs.
Exactly. Johnson built on Truman's groundwork and harnessed the spirit of the Great Society to finally address healthcare access for those vulnerable populations left behind by the employer system.
And that led to the landmark legislation in 1965.
The Social Security Act amendments of 1965, creating both Medicare and Medicaid. Huge pieces of legislation.
Can you break down the difference between the two again?
Sure. Medicare was set up as a federal health insurance program primarily for people 65 and older, regardless of their income or work history.
Okay, federal for seniors.
Right. It had Part A, covering inpatient hospital care, mostly funded through payroll taxes, and Part B, covering doctor visits and outpatient care, which required a monthly premium from beneficiaries.
Got it. And Medicaid?
Medicaid is different. It's a joint federal-state program. It provides coverage for low-income individuals and families, as well as people with certain disabilities.
So eligibility and benefits can vary by state?
Exactly. Because it's a joint program, states have some flexibility, so eligibility rules and the specific benefits covered can differ depending on where you live. But it acts as that crucial safety net.
And I remember reading that President Truman was actually at the signing ceremony for Medicare and Medicaid.
He was. It was a really symbolic moment. Johnson lauded him, famously calling him the real daddy of Medicare, acknowledging that long fight.
Must have been quite something after his earlier efforts failed. What was the immediate impact of these programs?
It was significant and swift. By 1966, just a year later, approximately 19 million additional Americans had gained health coverage through Medicare and Medicaid.
19 million, that's huge.
It transformed access, especially for the elderly. Initially, Medicare Part A didn't have premiums, and Part B premiums were kept quite low.
But there's always a but. The costs started to rise quickly.
Almost immediately, yes. Concerns began to emerge about the rising costs of these massive new programs. Healthcare spending exceeded the initial projections quite rapidly.
So policymakers immediately faced this challenge. How do we control costs without hurting access?
That became the central tension, and it remains so today. By the late 1960s, Congress was already holding hearings about escalating Medicare bills and hospital expenses. That really set the stage for the next wave of reforms focused on cost containment.
And those growing concerns about cost really fueled the next major shift in American healthcare, starting in the 1970s, the rise of managed care.
Exactly. The feeling grew that the traditional fee-for-service model, where doctors and hospitals were paid for each service they performed, was inherently inflationary. It incentivized more care, not necessarily better or more efficient care.
So the focus shifted towards trying to manage the care and the costs.
Right. And the Health Maintenance Organization, or HMO, Act of 1973, signed under President Nixon, was a really pivotal piece of legislation in this move towards managed care.
What did the HMO Act actually do?
It provided federal funding and support for the development of HMOs. Perhaps more importantly, it required many employers, if they offered traditional insurance, to also offer an HMO option if one was available locally.
So it sort of forced HMOs into the market.
It gave them a significant foothold, yes. The core idea behind HMOs was this capitated prepaid model. Providers received a fixed payment per patient per month, regardless of how many services that patient used.
The theory being that this would incentivize them to keep patients healthy, preventive care.
That was the goal, yes. Incentivize preventive care and more efficient utilization of resources, rather than just ordering more tests and procedures.
Were there existing models for this?
Yes. California's Kaiser Permanente was an early and quite successful example of this kind of integrated HMO model. They focused on comprehensive care and prevention within their own system of hospitals and doctors. Kaiser's model definitely influenced the HMOs that popped up after the 1973 Act.
And did people sign up for these HMOs?
They did. We saw rapid growth in HMO enrollment through the 70s and 80s. Millions were attracted by the promise of lower premiums and lower out-of-pocket costs compared to traditional insurance.
But it wasn't all smooth sailing, was it? I remember hearing about the managed care backlash.
No, it definitely wasn't smooth sailing. That backlash was real and significant. Consumers started getting frustrated with the strictness and limitations of many HMOs.
Like needing a referral from your primary care doctor, the gatekeeper, for everything.
Exactly. Gatekeepers needing prior authorization for tests or procedures, being restricted to a narrow network of doctors and hospitals. People felt their choices were being severely limited.
And doctors weren't always happy either.
No. Physicians raised concerns about the increasing administrative burdens, all the paperwork, and the potential for the financial incentives within HMOs to compromise patient care. The fear that decisions were being driven by cost, not by medical need.
There was that saying, right? HMOs did much more to manage costs than managed care, sometimes at patients' expense.
That quote really captured the public sentiment at the time. And in response to these widespread criticisms, we saw the emergence of preferred provider organizations, or PPOs.
PPOs were seen as a compromise.
Kind of a middle ground, yes. PPOs offered a wider network of providers and more flexibility. You could usually see doctors outside the network, although you'd pay a higher share of the cost. It offered more choice than a strict HMO.
So people were willing to pay a bit more for that flexibility.
It seemed so. By 1990, HMO enrollment had grown substantially to around 37 million people. But the rapid growth of PPOs alongside them signaled this growing preference for choice and flexibility, even if it came with slightly higher costs.
And hospitals and doctors were pushing back too.
They were definitely pushing back against the level of control that payers, the insurance companies, were exerting over how healthcare was delivered. Congress even responded by partially repealing some of the earlier HMO mandates in legislation like COBRA and HIPAA, further promoting consumer choice.
It's interesting, though, you mentioned Kaiser Permanente. They continue to operate successfully.
Yes, Kaiser remained a prominent example, demonstrating that an integrated model could potentially deliver high-quality care in a cost-effective way. But the broader trends of the 80s and 90s really showed this public weariness with very narrow networks and significant limitations on healthcare choices. The debate broadened beyond just how we pay for care to how care is actually delivered and accessed.
Which brings us closer to the present, to the late 1990s, and another major shift, this time within Medicare itself, the creation of Medicare Advantage.
That's right. The Balanced Budget Act of 1997 created what was initially called Medicare Plus Choice, later rebranded as Medicare Advantage, or MA.
And what was the fundamental change here?
This legislation allowed private insurance companies to offer Medicare benefits through their own managed care plans operating under contracts with the federal government. It was a significant move away from the traditional government-run fee-for-service Medicare program that had existed since the 60s.
So seniors could choose a private plan instead of traditional Medicare.
Exactly. And these private MA plans often bundled in extra benefits not covered by traditional Medicare. Things like vision care, dental coverage, hearing aids, and often prescription drug coverage. Part D, which came later but was integrated into many MA plans.
Which obviously made them quite appealing to many beneficiaries.
Very appealing. And as a result, we've seen steady, significant growth in MA enrollment over the last 2 decades plus.
To the point where now a majority of Medicare beneficiaries are in these private plans.
That's correct. By the early 2020s, roughly 60%, clear majority of people eligible for Medicare were enrolled in a Medicare Advantage plan.
Wow. So that essentially transformed Medicare from a purely public program into this huge market opportunity for private insurance companies.
It absolutely did. And what's particularly striking is the high degree of market concentration that developed within this MA market.
Meaning just a few big companies dominate.
Very much so. In 2024, it was reported that in over 90% of counties with MA plans, a single insurance company held a market share of 30% or more.
That's not a lot of competition in many areas.
No. And you see companies like United Health Group holding a very large chunk, around 29% nationally. Just 4 large companies, United Health, Humana, Aetna, now part of CVS, and Elevance, formerly Anthem, collectively cover about 65% of all MA enrollees.
That's a huge amount of influence concentrated in just a few players. Now, how do these plans get paid? It's not fee-for-service, right?
No, it's based on a system called risk adjustment. The government pays MA plans a set amount per enrollee, but that amount is adjusted based on the health status or risk score of the patient. Plans get paid more for sicker enrollees.
What's the rationale for that?
The idea is twofold. First, to ensure plans have adequate resources to care for sicker, more expensive patients. And second, to discourage plans from selectively enrolling only healthy people, which would undermine the risk pool.
But that risk adjustment system has become quite controversial, hasn't it?
Extremely controversial. Critics argue, and numerous investigations suggest, that it creates powerful financial incentives for plans to make their patients appear sicker on paper than they actually are, a practice known as upcoding.
Exaggerating diagnoses to get higher payments from Medicare.
That's the allegation. And we've seen hospitals and doctors complaining, too, about the administrative burden of dealing with all these different MA plans, each with its own rules and requirements, and facing payment denials or delays.
And with so few large insurers dominating, providers don't have much leverage to negotiate.
Their leverage is significantly limited. So the MA era definitely brought more private plan choices to seniors, often with those attractive extra benefits. But it also meant that a handful of very large insurance corporations gained unprecedented influence over billions in federal Medicare spending, profoundly shaping how healthcare is delivered to millions of older Americans.
And this rapid growth and the structure of Medicare Advantage, particularly the payment system, has led to intense scrutiny, especially in the last few years, concerning fraud, waste, and abuse.
Intense is the right word. In 2024, federal investigators reported uncovering potentially billions of dollars in suspicious payments made to MA plans. It's a staggering amount.
Billions? What kind of suspicious payments?
Well, a really significant report came out from the HHS Office of Inspector General, OIG, back in 2022. They looked at MA payments and found something quite specific.
What did they find?
They found $7.5 billion in MA payments were linked to diagnoses that appeared only on health risk assessments. You know, those often done through brief home visits or screenings by third-party vendors. But there was no record of the patient actually receiving care for those diagnosed conditions in their regular medical encounters.
So plans were getting paid more because a form said a patient had a condition, even if their doctor wasn't actively treating it.
Exactly. It strongly suggested widespread upcoding, adding diagnoses, sometimes inaccurately, just to inflate those risk scores and capture higher government payments, leading to potentially unnecessary spending and wasted public resources. It reveals this core tension. How do you bring market forces into a public system without opening the door to profit-driven behaviors that might undermine the program's goals?
That's a huge problem. And did the OIG find this was concentrated in certain plans?
They did. The report highlighted that just 20 specific MA parent companies accounted for about 80% of those questionable payments.
Wow, so not evenly spread. And it's not just about the payment codes, right? There have been concerns about marketing, too.
Yes, absolutely. Regulatory agencies have raised serious concerns about aggressive and sometimes misleading marketing practices used by some MA plans and the brokers who sell them.
Like what kind of practices?
Well, in late 2024, the HHS OIG issued a specific special fraud alert. They warned about potential kickback schemes where brokers or agents might be receiving improper payments or gifts to steer seniors towards particular MA plans, regardless of whether that plan is actually the best fit for the senior's needs.
So seniors could be pressured or misled into enrolling in plans that might have restrictive networks or higher costs than they realize.
That's the major concern. Investigators found evidence suggesting these questionable incentives were being used, potentially harming beneficiaries. It signals a real shift in regulatory focus towards cracking down on these marketing abuses.
And it seems like whistleblowers have played a big role in exposing some of this.
Whistleblower lawsuits have been absolutely crucial. Under the False Claims Act, individuals with inside knowledge can sue on behalf of the government. The Department of Justice has intervened in several high-profile cases alleging that major insurers systematically inflated risk scores.
Can you give some examples?
Sure. In 2023, the DOJ intervened in a case against Anthem, which is now Elevance Health, alleging they submitted inaccurate and inflated diagnosis information. Back in 2019, Sutter Health agreed to a $30 million settlement over allegations of submitting unsupported diagnosis codes for their MA enrollees.
So big names and significant settlements.
Yes, and there have been other major cases involving companies like Freedom Health Optimum and Group Health Cooperative, which is now Kaiser Permanente Washington, resulting in multi-million-dollar settlements for improper coding practices. The Justice Department has explicitly stated that combating MA fraud is now one of its top priorities.
That suggests we'll see even more enforcement actions.
It strongly indicates that, yes, they are clearly focusing resources here.
But the concerns go beyond just the money, the coding, and the marketing. There are also worries about the actual care patients receive in MA plans, right? Potential for denials.
That's a critical point. Alongside the payment issues, there are growing concerns about the adequacy of care and the potential for MA plans to deny necessary medical services.
How would they deny services?
Primarily through mechanisms like prior authorization. Reports have highlighted how these requirements, where the plan has to approve a service before it's delivered, can create significant barriers and delays to getting timely care.
And the argument is that the financial incentives might encourage denials.
Yes. The argument is that since MA plans profit by spending less on care, as they receive a fixed payment per member, there's an inherent financial incentive to potentially prioritize cost containment over authorizing optimal, though perhaps more expensive care.
And then there's that trend of vertical integration you mentioned earlier, insurers buying up doctor practices and clinics. How does that fit in?
That adds another layer of complexity and concern. When the insurer also owns the providers, it raises potential conflicts of interest. There's an incentive to keep patients within their own network, even if the best specialist for a particular condition is outside that network. It can limit patient choice and potentially stifle competition.
So summing up this recent period, 2020 to 2025, really seems to be a time when Medicare Advantage has come under a microscope.
Intensely so. Federal investigations, regulatory warnings, major whistleblower lawsuits, they've all exposed significant vulnerabilities.
And the focus has broadened.
It really has. It's moved beyond just risk adjustment payments to include serious questions about marketing ethics, access to care, service denials, and the impact of market consolidation and vertical integration. All these developments strongly suggest a need for much greater oversight and reform to ensure the integrity of the program for both taxpayers and the seniors who rely on it.
The ongoing legal and regulatory actions definitely indicate this will remain a major focus area.
No doubt about it.
And these kinds of controversies, the tension between private interests and public programs, the reimbursement battles, the service denials, they really ripple throughout the entire U.S. healthcare system, not just Medicare Advantage.
That's absolutely right. The increasing involvement of private for-profit healthcare companies in publicly funded programs like MA is a huge point of contention. Proponents will argue it brings efficiency, innovation, and choice.
While critics raise alarms about conflicts of interest, profit motives potentially overriding patient care, and the erosion of traditional public programs like Medicare.
Exactly. And focusing on MA again for a moment, that risk adjustment payment model we discussed is central to the controversy because it creates these direct opportunities for profit maximization through manipulating patient diagnoses.
The inflated risk scores we talked about.
Yes. Numerous reports, lawsuits, government audits allege these aggressive tactics like using those health risk assessments or retrospective chart reviews to add diagnoses that might not significantly impact the patient's current care purely to boost payments. The HHS, OIG, and DOJ are actively pursuing insurers for billions and alleged improper payments related to this.
And beyond the payment games, there's the impact on access.
Right. While MA plans might offer broader benefits on paper, concerns persist about actual access limitations and potentially higher rates of service denials compared to traditional Medicare.
That prior authorization hurdle again?
Prior authorization is a key tool used for cost containment, but critics argue it often delays or denies necessary care. Patient advocacy groups and some studies suggest denial rates can be higher in MA for certain services.
And the misleading marketing we mentioned.
It's another facet of this profit-driven environment. Intense competition leads some plans or brokers to use aggressive or confusing tactics. That HHS OIG fraud alert about potential kickbacks steering beneficiaries toward unsuitable plans is a stark warning. Seniors can end up trapped in plans with networks that don't include their doctors or with unexpectedly high costs.
But these issues aren't only in Medicare Advantage, right? Private insurance generally has its share of battles over payment and access.
Oh, absolutely. Reimbursement disputes and denial controversies are pervasive throughout the private insurance market.
Prior authorization is a big one there too, isn't it?
Huge. It's a major source of frustration for physicians and patients across the board. Insurers argue it's necessary for cost effectiveness, ensuring care is appropriate.
But doctors see it differently.
Doctors and hospitals often view it as a massive administrative burden that causes delays, burns out staff, and can actually harm patients if needed care is postponed. Physicians' offices spend an incredible amount of time just dealing with prior authorization requests, often for routine care. And there's often a lack of transparency and consistency in the rules across different insurers.
Then there's surprise billing.
Yes, that issue of getting an unexpected large bill from an out-of-network provider, even when you sought care at an in-network hospital. The No Surprises Act aimed to fix this.
But it hasn't completely solved it.
There are ongoing implementation challenges and disputes between insurers and providers about what constitutes fair reimbursement in those situations. Plus, related to that is the problem of network adequacy itself. Are there enough doctors and specialists in the network, especially in rural areas or for specialized care? If not, patients face higher costs or difficulty finding care at all.
And what about denials based on medical necessity? That sounds tricky.
It's incredibly tricky and subjective. Insurers frequently deny claims, arguing that the service provided wasn't medically necessary, according to their criteria.
But the doctor recommended it.
Exactly. This leads to major disputes when the treating physician and the insurance company disagree on the necessity of a treatment. There often aren't clear, universally accepted definitions, and critics argue that financial incentives can subtly influence an insurer's determination of necessity.
And patients are caught in the middle.
Yes, and they often lack the time, energy, or resources to effectively appeal these denials, potentially facing huge bills or simply foregoing the recommended care.
You also mentioned pharmacy benefit managers, PBMs, earlier. How do they fit into these controversies?
PBMs are powerful intermediaries. They negotiate drug prices with manufacturers on behalf of insurance plans and manage the plan's drug formulary, the list of covered medications.
So they influence which drugs are covered and how much they cost.
Correct. But there are significant concerns about their lack of transparency, potential conflicts of interest due to the complex system of rebates they receive from drug makers, and how their formulary restrictions impact patient access to medications prescribed by their doctors.
Could they potentially favor a more expensive drug if they get a bigger rebate for it?
That's a major concern raised by critics that the rebate system might incentivize PBMs to prioritize higher-priced drugs over potentially more cost-effective or clinically equivalent alternatives, driving up overall costs.
It feels like there's a constant stream of reports and investigations trying to shed light on all these complex issues.
There is. You see reports from the Government Accountability Office, GAO, highlighting things like improper Medicare payments or inadequate insurance network monitoring. The HHS OIG conducts audits uncovering overbilling and fraud. Congress holds hearings on drug costs or market consolidation.
Academic researchers study payment models and access disparities.
And investigative journalism plays a crucial role, too. Outlets like Kaiser Health News, ProPublica, the New York Times, they often uncover abuses by digging into patient stories, exposing things like surprise billing practices, the burden of medical debt, the role of private equity in healthcare, or the challenges patients face getting treatment for specific conditions.
And all these systemic issues, the reimbursement fights, the denials, the complexity, they have a real profound and often devastating human cost, don't they?
Absolutely profound. We're not just talking about numbers and policies. We're talking about people's lives and well-being.
Like crushing medical debt.
Crushing medical debt is a huge one. Shockingly, many Americans with health insurance still face crippling debt due to high deductibles, high coinsurance, and denied claims. Investigations have shown over 100 million Americans struggle with medical debt.
Forcing impossible choices.
Yes, forcing people to choose between paying for health care and paying for basic needs like food or housing. Medical bankruptcy, tragically, remains reality in the U.S.
And the fear of those costs, or the hassle of fighting denials, leads people to put off getting care.
Definitely. Prior authorization hurdles, claim denials, just the sheer worry about cost that leads many people to delay or completely forego necessary medical care, whether it's a checkup, a screening, or treatment for a chronic condition.
Which can obviously make things much worse down the line.
It can worsen conditions, lead to more expensive emergency room visits later, and ultimately result in poorer health outcomes. The fear of financial ruin is a genuine barrier to seeking timely care for millions.
And the stress of it all.
The emotional distress and anxiety are immense. Imagine dealing with a serious illness while also having to battle your insurance company over coverage, navigate complex bills, and live with the uncertainty of potential debt. It takes a huge toll.
And it must damage people's faith in the system.
It absolutely erodes public trust. When patients feel like their insurance company prioritizes profits over their health, or when they constantly face reimbursement battles, it undermines confidence in the entire healthcare system. You feel like you're fighting the very entity that's supposed to help you.
It affects doctors and nurses too, right? This constant battle.
Immensely. Healthcare providers face enormous administrative burdens, especially with things like prior authorizations. It's incredibly frustrating for them to spend hours fighting for care they believe their patients need.
That sounds like a recipe for burnout.
It is. It contributes significantly to physician and nurse burnout, and also to what's called moral injury. The distress felt when you know the right thing to do for your patient, but are prevented from doing it by systemic barriers, often financial ones. Witnessing patients suffer due to cost or insurance issues is deeply demoralizing for providers. It's interesting how often the established players can be wary of changes that might disrupt the status quo, even if those changes could benefit patients.
So, given all these deep-seated problems and the very real human cost, where do we go from here? What are some potential paths forward towards a maybe more equitable and sustainable system?
It's the million-dollar question, isn't it? And there's no single magic bullet. It really requires a multifaceted approach to tackle those perverse incentives, the lack of transparency, and that fundamental tension between private interests and the public good.
So what are some of those potential avenues for change?
Well, one area is definitely strengthening regulatory oversight. That means stricter enforcement of rules around risk adjustment coding and Medicare Advantage, cracking down on misleading marketing, and holding insurers accountable for inappropriate claim denials, both in MA and private insurance.
So more robust enforcement of existing rules and maybe new ones.
Exactly. Another key area is reforming the underlying reimbursement models. Moving away from the traditional fee-for-service system towards models that pay for value and quality outcomes, rather than just the sheer volume of services, could align incentives better.
Value-based care, they call it.
Right. Then there's the huge issue of transparency. We need much more transparency in insurance pricing, in how prior authorization decisions are made, And in the dealings of those pharmacy benefit managers, understanding the flow of money and rebates.
Shining a light on the black boxes.
Precisely. Addressing network adequacy is also crucial. We need stronger standards to ensure insurance networks actually provide meaningful access to in-network care, especially for specialized services and in rural communities.
So you can actually use the insurance you pay for.
Right. And standardizing the criteria for medical necessity could help. Developing clearer, more consistent definitions across different payers might reduce some of those arbitrary-seeming denials and disputes.
What about the bigger picture structural changes people talk about?
Well, the debate continues around exploring public options, like allowing people to buy into a Medicare-like plan, or even moving toward universal coverage models, like a single-payer system.
And what are the arguments there?
Proponents argue these approaches could streamline administration, exert greater control over costs, and ensure truly equitable access for everyone. Opponents raise concerns about government overreach, potential limits on patient choice and provider autonomy, and potentially stifling innovation. It's a deeply ideological debate as well as a practical one.
So it's clear the American healthcare system is really at a critical juncture. Maybe it always feels that way, but the current controversies seem particularly sharp.
I think that's fair to say. The issues we've discussed, the MA scrutiny, the reimbursement battles, the access challenges, the human cost, they really underscore an urgent need for meaningful, thoughtful reform.
And it won't be easy.
No. Addressing these challenges will require a comprehensive and sustained effort from policymakers, insurers, providers, employers, and patients themselves. It demands collaboration and a willingness to confront uncomfortable truths about how the system currently works and for whom.
The choices made today, or the choices not made, will really determine the future of healthcare access, affordability, and equity in this country for decades to come.
Absolutely. It requires careful consideration of the ethical principles involved, the complex economic realities, and what we believe is the fundamental right to quality, affordable healthcare for everyone in society.
And that brings us to the end of our journey through the winding and often turbulent history and current state of the American healthcare system. Quite a ride.
It certainly is.
If you found this deep dive insightful, and we hope you did, we really encourage you to subscribe to the deep dive for more in-depth explorations of important topics like this one.
Yeah, definitely hit that subscribe button.
And we also want to give a special shout out to our podcast, Runner Stories on MD Talk. If you enjoy thoughtful conversations, maybe something a bit different, we think you'll like it.
Check it out.
Please find Runner Stories on MD Talk wherever you get your podcasts and subscribe. And maybe share it with someone you think might find it interesting. That always helps.
It really does.
For even more content from them, you can also subscribe to their newsletter over at mdtalk.substack.com.